Hello, everyone. I'm Donald Manlapas, and I'll be discussing the introduction to musculoskeletal evaluation. So, I'm a faculty member of the college since 2007, and whether you like it or not, I'm the department chair of the physical therapy department. And I'm wearing my hat right now as lecturer for your MSK examination. So I'll be with Ma'am Giselle and Ma'am um, Tina Devora to help me discuss the different components of musculoskeletal examination per region. So, what are the components of a physical assessment, and how does musculoskeletal um, relate to physical therapy skills and practice? Actually, these components, you've heard this one and you practice this one in your introduction to PT. You had your vital signs. I remember I was with you during that time, together with the fourth year when we visited one of the communities in Bulacan. Or I think maybe some of the CleanEd faculty um, were with you during in the, I think, Navotas community. You did your observation and ocular inspection via your postural assessment. And then you had your palpation as your third year practical exam. So you already have this range of motion principles, musculoskeletal, manual testing, and sensory evaluation um, in your intro to PT. But the role of musculoskeletal examination is actually to dovetail everything. You've learned these things in chunks, like you had your MMT, just the basic. You had your sensory evaluation, just the basic one. But MSK will go into different regions and will go deeper examination of a particular muscle, of a particular joint, or any structures that is related to the pathology of a specific patient. So, musculoskeletal examination is really a core of physical therapies because, or really core of physical therapy because if you don't have a really good examination, if it's inaccurate, if it's actually not valid, then you cannot create a good intervention or plan of care for your patients. Okay, so sensory evaluation. I know some of you, I've noted that some of you in the different class that I had last Saturday, just the principle on how to check the dermatomes and dermatomes particularly and a different body site area in the body, particularly the knee. I think they mentioned about the shoulder for other sections. So I hope we're on the same page on this um, introduction to PT. But don't worry because we will do spiraling technique wherein we will check the gaps. What are the knowledge that you need to know so that we can move forward with the deeper examination of musculoskeletal examinations. Okay, so where does MSA lies in the curriculum? So you heard the word SOAP notes, right? So SOAP stands for the SOA, and you have your P. Your S is the subjective, O is objective, A is assessment, and P is plan. For first term, you'll be doing S and O, which is actually subjective and objective. This is your musculoskeletal examination. Well, towards now the second term, you'll be doing A and P, assessment and plan. And that will be your musculoskeletal evaluation and intervention. So, in the first term, we want you to develop the skills of interviewing a patient and the skills of doing a systematic way of assessing a particular patient. In A and P, we'll teach you how to do a specific goal and of course, identify and select a plan of care or a very good intervention for your patient. So you have your intervention. Mm-hmm. So I'll spell this out one. So intervention. All right. So for your SNO, we need to collect everything. Collect particular measurements, outcomes that is objective, of course, and at the same time valid and reliable so that you can create a goal for your patient and give a plan of care. So for example, your patient has a limited range of motion. Upon, for example, the shoulder, upon doing shoulder flexion, you noted that the patient cannot complete the full range of motion, which is 0 to 180 degrees. So during your second term, you'll ask to write a goal. Like for example, I want to increase at least 10 degrees of range of motion of the shoulder. And then during your lab and lecture, you'll discuss some of the intervention for that. Will I do stretching? Will I do joint mobilization? Or maybe you can apply the things that you will learn from your physical modalities in order to increase maybe the strength. That will be possible as well. So aside from those components of physical therapy assessment that I mentioned to you, we'll be also doing neurological examination. And the core of this MSK is your special test or a special maneuver to confirm or to refute a specific condition or in PT impression. Postural assessment, you've done this one. Functional assessment and gait analysis will actually discuss towards the end of the first shifting, and towards the last part of our course, we'll be doing the gait analysis. All right. So the first and the most important is actually observation or looking or an inspection phase. So this is actually to gain visible defects or functional deficits or abnormalities in the alignment. Particularly, we have here a photo of a particular individual, which is actually a forward head posture, right? So you see the head is actually um, uh, protracted, but also if you look at the shoulder, it's also protracted, and the other side is the normal one. So this might begin in the waiting room or as a patient being taken into assessment area. Is the patient ambulatory? Is there an assistive device? Like for example, if she or he is walking with the bilateral axillary crutches. Observation guidelines includes that you should position so that the dominant eye is used. So in the laboratory, we'll teach you how to determine your dominant eye. Both sides of the patient should be compared simultaneously. One of the guidelines that we have is to assess first the normal side or the unaffected side, followed by the affected side. So, for example, if the case is right shoulder adhesive capsulitis, then you need to assess first the left shoulder. Know the normal body alignment. This is also an important thing, an important message to you that you need to go back to your basic sciences, your anatomy, your kinesiology, even your physiology. You need to take note of that. And at the same time, you need to um, think and correlate different conditions that I think the orthopedic or the medical surgical courses that you had be connected with the one that we'll be doing in your musculoskeletal examination. So you need to go back again and review those things. So some of the guide question: is there any obvious deformity? Okay, particularly for example, we've seen that the patient has a deformity in the foot. Like for example, it is actually um, uh, drop. There's a foot drop. You see a deformity. You see maybe deformity in the scapula. For example, the left scapula is higher compared to the right one in a static position. Are there any bony contours of the normal body of the body, normal and symmetric, and there's an obvious deviation? So I think you've discussed this one in your postural assessment. Are the soft tissue contours normal and symmetric? So you see you will also note this one during your palpation phase. Is the limb position equal or symmetric? More questions? Are the color and the texture of the skin normal? So as a PT, we should note the integrity of the skin. We should know the integrity, for example, of a wound. If a patient has bruise, so you need to check, you need to see it ocularly on observation. What is the integrity of these structures? Are there any scars that may indicate recent injury and surgery? This will tell you that the patient might have a post-surgical procedure, like for example, total hip replacement, or maybe a surgical procedure due to fracture. What is the attitude, or what attitude that the patient appears to have towards condition or towards examination? We will try to help you do an interview, history taking, like for example, if the patient is a bit depressed because of the condition, or the patient is irritable, because for all you know, most of the patient will come to the clinic because of pain, and because of the pain, they are very highly irritable and might for example, don't want to be disturbed. Okay, so how do we interview them, and how do we perform these assessments? What is the patient's facial expression? That's also very important. And is the patient willing to move? Okay. So, on the other hand, after an observation, you have your examination. And we use this one to confirm or refute the suspected diagnosis based on the history and observation. If you downloaded my lecture notes, you will see there the different components of physical examination, particularly the word diagnosis. Is there a correct diagnosis, a medical diagnosis? And as a PT, we'll have also our PT diagnosis or our PT impression. So, obtain valid consent to perform this examination or special test. It should be voluntary. Inform procedures to be done, and patient must be legally competent to give consent. So you need to ask the consent of consent of the patient. So you ask them, like for example, ma'am, sir, okay lang po bang hawakan ko po kayo dito sa shoulder? Okay lang po bang tanggalin po natin yung damit para makita ko po yung likod para po ma-assess namin mabuti? So you need to give that um, um, paalam or consent to the patient. So what are the red flags? So severe unremitting pain, pain affected by medication or position, severe night pain, severe pain with no history of injury, severe spasm, and a psychologic overlay. So these are the red flags wherein wait, stop the assessment. Of course, the first thing that you need to do is to do your vital signs. And if you have a patient with who is hypertensive, and you check the vital signs are beyond the normal one, then you also raise the flag for this one that maybe you won't need to assess the patient, or at this point you don't need to proceed with your assessment. So my point is, before assessing the patient, make sure these things are being checked, and at the same time the vital signs are normal. So what we put actually in our notes is that the patient was seen but not assessed, or patient was seen rather but not treated. So these are the things that you need to take note. The meaning of psychologic overlay is more on the irritability of the patient, and if the patient is also depressed, or maybe the other way around, very happy, or very happy in a sense that, oh, he or she is not really in his normal aura. So what are the principles of examination? As I mentioned to you, normal side is tested first. You should start with active, passive, and resistive isometric movements. Any painful movements are done last. Apply over pressure, also done last. And each movement may be repeated several times or held in a um, certain amount of time. Okay, so on the next slide, you will see the principles of assessment, particularly with manual muscle testing. Resisted isometric movement are done with the joint in resting or neutral position. And you need also to check passive structures or ligaments. It is not only the degree of the opening, but also the quality of the opening is very important. So the opening means, like for example, if I straighten my elbow joint, So there's a particular position wherein you need to put that specific angle of the joint so that you can do your maneuver. Okay? Why? For example, if I extend my elbow, you know that your olecranon process is in the olecranon fossa. And if I try to move, give a distraction or give a stress, particularly in the elbow, then you cannot do really those movements because it is actually locked. Okay? Appropriate stress is applied gently and you may repeat it several times. Of course, in this examination of special or doing the special test, you might provoke the pain, so you need to be very careful. When testing myotomes, each contraction is held for 5 seconds, minimum of 5 seconds, and you note that in your manual muscle testing. Warn the patient for possible exacerbation of symptoms as a result of the assessment, as I mentioned to you, and refer if necessary. So if you see some red flags, you need to, like for example, if you're an intern, you need to take note of that and report that to your clinical supervisor. Okay. So mostly if you're a PT, like for example, if you're a PT in the United States, we need to refer them to a medical doctor. Okay, we don't want to be sued by a specific patient or or insurance company by exacerbating the condition of your patient. So in your laboratory, you will teach how to do a step-by-step procedure and at the same time a step-by-step procedure of assessment and at the same time how to do history taking. But usually you start with the arrangement is you start with vital signs. And after doing the vital signs, you will do history taking. So you will do history taking for your patient. So history taking. So you need to interview the patient. What is the mechanism of injury? Okay. What is the past medical history? Why you are here in the PT and referred for rehabilitation? So those things you need to learn that. So vital signs, history. Then you do ocular inspection. Okay. You try to do general ocular inspection from head to toe, and at the same time, you will also check, move some of the limbs or some of the body parts to view a specific area. Like if you want to check the integrity of the skin, you after that you can do active range of motion. So remember, active first before passive assessment. So active range of motion. So after active range of motion, you do your PROM, your passive range of motion. And since you're doing the passive range of motion, towards the end, what you can do your end field. Okay, so check the end field. So if it's soft, if the end field is hard, if the end field is firm, which is the most common one. So you have your history, OI, ROM, PROM, and end field. And then the next thing that you need to do is you can do now your MMT or your manual muscle testing. Okay. The last of this physical assessment component is actually doing your palpation, okay, and your special test. Okay, so this done last, your special test and your palpation. Again, these things are done last. Why? Because if you do your palpation and special test, as I mentioned to you might trigger some of the um, um, condition. Maybe you trigger particularly pain. And what will happen if you do all the assessment, if you start with palpation and your sensory, your not sensory testing, but your special test, then you will have a false positive result in your MMT and in your range of motion, right? Tama naman, di ba? Pag ginalaw ko na to, sumakit siya, what will happen is that maybe the patient cannot do active range of motion because it is painful. And ikaw naman, as a PT or as an intern, you will note that, oh, 60 degrees ang kulang niya sa range of motion. And that's false positive, right? So I hope you got this one. So this is again the arrangement, vital signs, history, ocular inspection, your range of motions, and your end field, your MMT, palpation, and your special tests are done last. Again, this is the procedure on how you do the assessment. This is not the order on how you write your SOAP notes, particularly the objective part. Okay, this is not the correct arrangement. This is more or less the way you do your examination. But one of you may ask, will I do all of this assessment? So it depends. So our goal also, or our role rather, is to help you pick the most appropriate or select the most appropriate evaluation tool for a specific condition, right? So the scanning and screening examination to ensure that all possible sources of pathology are assessed. So I told you if you have some pain in the shoulder, maybe you can do also scanning on the neck area because the pain might not be coming on the shoulder structures but might be coming from your neck structures or neck area. Perform rule out the possibility of referral or symptoms specially to the spine. Like for example, in the spine, you have your dermatomes, right? And it's overlapping. So the special test will give us more or less an assessment or an examination result wherein you need to do at least three special tests. One, one special test or two special tests to confirm the condition, and we need to do a rule out. Okay, at least one rule out for our case. So we'll have a separate discussion of your special test. I think that's the third lecture. And with any doubt about where the pathology is located, of course, you need to ask your supervisor or ask the doctor. Quick look or scan on the part of the body parts of the examination, the spine and extremity is very important. So this is how we arrange the course. So we start first with the shoulder during the first shifting as our representative case, and then we go to the upper extremity and spine in the second term or second shifting rather, and the lower extremity for the last shifting. So I think they will discuss you as well that in the orientation. So this is how we do our examination. This is a good model and a photo on a step-by-step examination. So you had your history taking, and then provided that you had your vital signs already there, and then your observation, and you will do first the active, then the passive, then we have your resistive or resistance examination. We'll do a separate discussion for the spinal, and we also will have separate discussion for your peripheral joints, such as your shoulder, elbow, wrist, and hand, your hip, knee, and your ankle and foot. All right. So, what are the active movements, or AKA active physiologic movements? These are combined tests of range of motion, control, muscle power, and patient's willingness to perform a movement. So again, this should be it should be the patient moving a specific region. So it is actually dependent, of course, in muscles, contractile tissues, nervous, and inner tissue. Okay, so may be abnormal for several reasons, and it should be differentiated. So again, we'll have a separate discussion about it. Differential diagnosis. Is the active movement not performed because of pain, muscle weakness, or maybe paralysis, or maybe spasm? Okay, or maybe there's a tightness of a specific structure. Not perform at all or perform with caution during fracture healing, or if the movement could put stress on the newly repaired tissues. As I mentioned to you, you need to check the red flags, and you don't need to move everything, particularly if the patient has a precaution in a specific range of motion. I think you noted this one in your total hip replacement when you're doing your positioning and turning. I'm really sure that they've mentioned about it. Then the standard movement allow for cardinal planes. So the cardinal planes are your flexion, extension, abduction, adduction, and your internal and external rotation. So this is an example of an active movement when wherein they combine movements and repeat the motions. Like if you instruct a patient to put his right hand on the superior angle of the scapula, and the other hand, like this one, and the other hand is actually at the back, reaching for the inferior angle of the scapula. This is actually a special test already, and we call this one Apley scratch test. So like it's like a scratch. So Apley scratch test is actually a special test to quickly test the range of motion of the shoulder joint. Because why? For example, in my right shoulder, I'm doing what? I'm doing flexion, very good, abduction, and external rotation. While on my left shoulder, if I reach for the inferior angle of the scapula, I'm doing adduction, I'm doing extension, and internal rotation. So that's the quickest way to check the range of motion of the shoulder. And you're doing already a special test. Again, this is called Apley's scratch test. So active movement you can apply over pressure, but you should be careful, particularly at the end range. So no symptoms and end field is normal, and movement is also normal. What do I mean with that? So there's really no normal because it can be firm, it can be soft, and it could be a painful one, and we call this one an empty end field. Empty end field is actually a painful end field. So you may decide that passive movement are unnecessary already. So it depends on your assessment and it depends on the condition of the patient. So some guide questions with the pain, the onset, the intensity, and the quality. You'll be asked, you will ask your patient, where can you please pinpoint the painful area? For example, this one, and the patient may tell you, actually it's dull, okay, or maybe it's localized just here, so it means it's not diffuse. And you will ask the patient to assess or measure the pain, wherein 0, no pain, and 10, worst possible pain. 0, no pain, and then you will ask the patient, oh, from 0 to 10, saan niyo po nararamdaman, ano po yung nararamdaman niyo? 0, wala pong sakit. Yung 10, yung pinakamasakit. And the patient will tell you, oh, it's around 4/10. Okay? So the reaction of patient to pain when you do your palpation, is there any observable amount of restriction? What is the pattern of the movement? And what is the observed rhythm and quality of the movement? You need to check on this one. And of course, lastly, is there movement of associated joint? Like for example, if there's a pain in the hip, will there be a concomitant pain in the knee and the ankle region? Okay, it's a question also that you need to ask the patient. And the last one is the patient willing to move the part? Okay. On the other hand, that's active movements. Passive movements, of course, you're the therapist, you're the one moving a specific joint or a specific structure. So usually the range of motion is slightly greater than the active movements. Patients should be relaxed. Okay. So again, it's the same question with pain, with the pattern of limitation, the end feel, associated joint affectation, and of course the range of motion available. It's also the same. So you can ask the patient whether it's pain-free, full range of motion. So there's no lesion of the inner tissue being tested by that passive movement, and there may be lesion in the other direction around the joint. So it can be pain-free and full range of motion. So I think this one, normal. But sometimes, pain and limited range of motion in every direction. This will help you to differentiate specific condition. Is it adhesive capsulitis? Because it follows a specific pattern, right? So there's a capsular pattern. Or it can be a bicipital tendinitis. So pain and limited in every direction. So you try to think, or in any direction in that matter. Pain and excessive or limited range of motion in some direction. So it can be non-capsular in presentation, there may be internal derangement in the shoulder, in the elbow, or in the hip, or there may be a torn ligament, or what we call your sprain. Pain-free and limited, so it's pain-free, but there's a limitation of motion. Maybe you can check the end field. It's usually bone-to-bone type, right? And maybe it may be indicate symptomless osteoarthritis or a non symptomatic condition. So you need to check on this inner tissue lesions. Then you do your MMT. So I think you had the principle in doing MMT by doing some resistance. You need to palpate also if there's some palpable contraction, and maybe you can assess the patient with no trace of muscle contraction at all. So we use the muscle strength grade of 0, which is no trace, and 5, which is actually normal. So again, same strategy. So check if there will be some differentials, like if it's a muscle strain, you check on the pain. If there's some peripheral nerve injury, an upper motor neuron lesion, or a tendon pathology, avulsion, and a psychologic overweight. You see, it's overlapping, right? So you need to check whether if it's for this slide, an upper motor neuron and a lower motor neuron lesion. When we talk about upper motor neuron lesions, these are the lesions affecting the central nervous system. Like, for example, stroke, TBI, if you have spinal cord injury. When we talk about lower motor neuron, it starts actually in the anterior horn cell, wherein, for example, some examples of lower motor neuron diseases are polio, spinal muscular atrophy, and you will learn that soon. But I think most for the musculoskeletal, it will be your peripheral nerve injuries. These are example of these are, you know it, carpal tunnel syndrome, radial nerve palsy. I think those things that mentioned to you during your orthopedic medical surgical background course. All right. Some guide questions. Again, you check for the intensity of pain and the quality of pain. What is the muscle strength? What type of contraction is causing the problem? Is the type of contraction causing the problem will be an eccentric type of contraction or more a concentric type of contraction? No pain, movement is strong. So no lesion on the contractile tissues, but you need to check the passive structures. So no pain, movement is strong. The other one is pain and movement is relatively strong. So maybe you can check on the muscles, the amount of the strength of the muscle, the tendon, and of course, if there's some avulsion fracture, meaning there might be some tendons. So remember, tendons connects muscle to bone. There may be fracture and there's a chip of bones that is avulsed, or maybe a tendon in the finger. So there's an avulsion fracture. So you need to check on that. Pain and movement is weak. So this might be severe lesions around the joint, like for example, fracture. No movement, no pain, movement is weak. So there's no pain, movement is weak. It can be complete rupture of the muscle or the tendon, involvement of the peripheral nerve, and you can differentiate, as what I mentioned to you, an upper motor on a lower motor neuron lesion. So for example, you have a stroke, left side of the left side hemisphere of the brain. So the manifestation is on the right side. So you will see some weakness on the side. So special tests. So special tests are performed after completion of the history, as I mentioned to you, the last part, and it is also known as a clinical accessory, proactive, or structural test. So strongly suggestive of clinical disease or condition where they yield positive results. Okay, and again, do not necessarily rule out the disease or condition where they yield negative result. You need further assessment. So special test is a physical examination. So if you confirm some of the condition, then you might want to relate that in your history taking, wherein patient might have a previous X-ray. So like for example, a shoulder dislocation or a fracture, then you perform some special tests. But definitely there's no special test to assess a fracture of the shoulder, but maybe an MRI, and then you'll check if there's a labral tear or the labrum, okay, or maybe a supraspinatus tendinitis. Okay, so you need to dovetail as well your physical examination with an ancillary procedure results. Okay. So findings to this test is dependent primarily to the skill and the ability of the examiner. So that's again our role to help you conduct a very appropriate and very correct way of doing special tests for your patient, and more accurately perform right after an injury under anesthesia or chronic conditions. But most of the time, the special tests are being done um, um, after an examination by the rehab doctor and referred to as a PT, and we'll do the special test during our assessment time. So most have not been tested for reliability, and sometimes for validity may be questions or may be questioned. So these are the things that you need to incorporate also with your research methodology. So they will teach you the concept of validity and reliability, and I think some for MSK will do also this concept. Okay, so should not be used in isolation, and it's not necessarily to learn all the special tests. Okay, we will learn those that are frequently used with clinical utility that is valid, reliable, sensitive, and specific. Okay, so prefer to use those found to be clinically significant, as I mentioned. So we use this one to confirm a tentative diagnosis, to make a differential diagnosis, and differentiate between structures. And of course, sometimes we use this special test to understand unusual signs. So again, you notice this one, signs and symptoms. So what's the difference between signs and symptoms? You should know this concept by now. So signs are objective, while symptoms are more subjective in nature. So some precautions. So again, careful in performing special tests, and it should be done with caution. Okay. So some contraindication are similar with the red flags. So severe pain, acute and irritable condition of the joint, the specific joints, and instability. If you have osteoporosis, pathological bone disease, active disease process, and of course unusual signs and symptoms noted by a therapist. And since we're also dealing with some neurologic signs, major neurologic signs might be contraindicated for a specific patient doing special tests. And lastly, of course, personality is very important, right? So patient apprehension must be also considered. So patient draping during physical assessment, similar in your laboratory. Um, Proper donning and draping. Females should wear bra or halter, or for us, bathing suit for the ladies, and for the guys, you should be wearing your cycling. Explain the patient that observation and detailed looking of the patient are integral part of the assessment. So ethical issues have been posted here. So you should be morally upright and ethical by explaining it to the patient carefully and using correct words. So this is very important because you cannot do assessment without, again, consent of the patient. So after examination, look back on history and pertinent findings in the exam. So Ma'am Giselle will teach you how to do history taking and to do documentation. And of course, determine what causing the patient's problem. And after that, if you have, again, a good S&O, you can design proper treatment regimen for the patient, and you will do re-examination of the patient if you are achieving your goal, the goal you set for your patients. This is our main textbook, so Orthopedic Physical Assessment by Magi. I love this book. You need to have this book because you will use this book from second year to internship, and if you plan to go to the United States and take the NPT examination, you need to use this book. So if you have any questions, you can just post or email me in your Blackboard Collaborate sessions, and you can also email us in our Google Drive. But of course, we'll post a link wherein if you have some questions, that it's a good discussion, particularly in the Blackboard. So thank you and good luck in your first term. And we're praying and we're hoping we'll have a good and a smooth musculoskeletal examination for this term and also for the whole academic year. Thank you and have a wonderful day.